Okay, thank you everyone for joining us today. It looks like it's top of the hour. We'll go ahead and get started in just a few seconds. Just a couple quick things. During the webinar, you can use your questions panel to submit any questions throughout the webinar. We'll try to get to those at the end. Handouts will be emailed to everyone that's attending after the webinar today. We had a couple technical issues that I had to deal with to get those prepared for you. So I apologize for that, but I'll get those to you right after the webinar this afternoon. And your certificates will be available this Friday by logging into your account. Sharon, if you're ready to get started, go right ahead.
I am. Thank you, Kim, and thank you everyone who's spending the next hour with us to talk about a topic that I am so passionate about. My name is Sharon Gibbons. I am a neonatal nurse practitioner by training, and currently I'm functioning as a senior administrator in a hospital in Toronto, Canada. So just a little bit of background, I have no financial relationships with manufacturers, and I don't intend to discuss any unapproved or investigative products. So we're here today to talk about infant pain management, and the question I ask of everyone is, can we do better in 2022? So I always like to start the talk with, well, what is the problem with pain management in infant? And really there's many myths that have existed for decades, actually, and I would challenge that some of these myths continue to exist today. So these are just some of them. Infants have immature CNS systems and can't experience pain. They don't have memory. Nurses know when an infant is in pain. Infants can tell you when they're experiencing pain. This one, and families have said it, infants can become addicted to opioids, and infants are unable to tell you that they hurt. So these are just some of the myths, and I think as long as these myths exist, we will continue to have challenges. But the goal today is really to look at those myths and see how we can do better. So the objectives for this session is to describe an approach to creating a comprehensive pain management program. And I'd love your thoughts on what me and our team are thinking about. Define pain and why pain is an issue or a problem with infants. Specifically for this audience, really look at sucrose, non-nutritive sucking, breast milk, breastfeeding, and kangaroo care. And then lastly, what can you do in your organization to manage procedural pain in infants? So this is a comprehensive approach that we've been working on for the last year, and we're looking at if the overarching goal or aim is to reduce pain in infants, there are really 5 different drivers that will get you to a comprehensive pain program. So under the primary drivers, what is a pain response? Like, what does pain look like in infants? Next, we have to discover or determine what are some pain management strategies. We could look at the environment in which an infant is in, how the team is working, and how is the family engaged in the pain management process. So for the topic of today's session is just one of them, and it's pain management. And you can look at the secondary drivers. It's really looking at pharmacological and non-pharm. Today we're looking at the non-pharm. And then it goes farther to say, what are the best practices you could do, and what are some of the change initiatives you could introduce into your area of practice to improve pain management. So the focus today is really pain management strategies, and in particular, the non-pharmacological approach. So let's start with what is pain. So pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. This definition has existed since the 90s, and for the first time changed in 2020 to say if it resembles that which is associated with pain, it should be considered painful. And they further went on to say pain can be acute episodic, acute recurrent, prolonged, persistent, or chronic. And then most importantly, as infants cannot verbalize pain, the onus is on us to evaluate their physiological, heart rate, breathing rate, blood pressure, behavioral, so crying, body movement, tone, or biochemical. So cortisol would be an example of a biochemical indicator. So the onus is on us to be able to interpret pain in infants. Sorry. So I pulled this forward from work that we did probably 8 years ago now, where we're describing how pain is processed and interpreted. So it begins with the transduction. There's 4 phases. Transduction is the first one, where there's actually a perception or a stimuli at the periphery. So it could be the skin, subcutaneous tissue, visceral structures, organ structures, and it ends at the spinal cord where substances are released. And these substances I'll talk about in the next slide, but it's the substance P. These substances are released from the damaged cells, which is how the pain transmission is translated. And it's at the level of the substance release where most of our pharmacological agents are working. So the next phase in the process is the transmission. So that's the release of these substances. And it's really, we're talking about substance P. It's released from the cells and it's transmitted to the brainstem, thalamus, and ultimately the cortex for interpretation. So all of us, including babies, have 2 types of pain fibers, and they're responsible for different types of pain. So we have our C fibers. They're large, unmyelinated, small diameter fibers, and they transmit pain impulses very slowly. So these are your dull, throbbing pain. Your A fibers are myelinated, large fibers, and they transmit very quickly. So infants have the integrity of both of these types of cells, and so they are capable of the slow, dull pain as well as the quick procedural pain. Next, we have perception of pain, and it's probably the hallmark of our myths where there's the belief that infants don't have the ability or a conscious interpretation of pain. So we know there's no single pain center responsible for the meaning of pain, and multiple systems work in parallel for the interpretation of pain. And lastly, modulation. This is where infants actually lack compared to older children or adults. Is the final stage, and it's the ability to the descending pathways from the brainstem to actually modulate the pain, to bind to the opioid receptors and inhibit the transmission of pain impulses. So while infants have intact A fibers and C fibers, what they lack is the ability to modulate. So although they can interpret pain, they are limited with their ability to do anything about the pain. So why do we care? Why is pain management so important to infants? So we know that the most common sources of pain in the neonatal unit, and probably in many pediatric units, the number 1 source of pain is heel lances, followed by IV starts, suctioning, the application of CPAP, whether it's the face or the prong. Those are the most common painful experiences. We know that infants have the anatomical and neurochemical capacities of pain, so we talked about those 4 phases as early as 22 to 24 weeks gestation. And we have seen in EEG and evoked potentials that there is evidence of cortical response to a noxious stimuli by about 26 weeks gestation. So infants' tactile perception thresholds are lower, as we talked about that last phase, and their ability to modulate pain is quite limited. So in all of us, the normal pain response to pain is the activation of our fight or flight response. When pain is prolonged in an infant, there is an alteration in the responses. So we can see an increased sensitivity to pain. So things that should cause pain are causing an increased, exaggerated level of pain for infants who receive multiple painful procedures. And the opposite is true. They can have allodynia. So studies have shown when there is a fake heel stick performed on a preterm infant, they have a pain response that is very similar to that of a real heel stick. So they are responding to something that should not cause pain. And if pain continues or is prolonged or persistent, the worst outcome is these infants no longer have the ability to mount a pain response. And so you often see this in the nursery when an intravenous is attempted. On the first attempt, there is quite a pronounced response to the painful procedure. But as the procedure is prolonged or there's multiple attempts to start the IV, that infant no longer has the ability to respond to pain. So it could be interpreted as there is no pain, but it is simply a depletion of their ability to mount a pain response. So this is the one that is most worrisome in the neonatal unit, infants who do not show any pain response. So we know infants experience about 15 painful procedures a day. Most of them are occurring within the first 24 hours of life, and those painful procedures diminish the longer they stay in the unit. There's very minimal non-painful procedures. In fact, in the first 24 hours of life, there is almost nil non-painful procedures. The work done by Grunow and team out in BC have shown that repeated pain does alter heart rate, breathing, blood pressure, intracranial pressure, and prolonged pain, unresolved pain, will affect wound healing, as shown in animal models, as well as some infant models. There's some suggestion that altered pain responses over time is seen in infants who've experienced multiple painful procedures, and there are changes to their cognitive or behavioral responses. So this is worrying if we continue to perform painful procedures without appropriate pain management. So we know that the early procedural pain affects the brain function and structure. It actually changes the way the brain perceives pain and is able to modulate pain. And we have seen decreased volumes of brain with infants who've experienced multiple painful procedures. So here are some of the things that you can think of in your unit as you approach pain management. One is what we call baseline. Avoid painful procedures. If it doesn't need to be done, if it can be deferred or something done in its place, that is the first and foremost approach to pain management. If something needs to be done, you can start moving down in the tiers. So tier 1 would be examples of a heel stick, a venipuncture, suctioning, and this is where the non-pharmacological, the focus of today's talk will be on, can be implemented. Tier 2 would be when topical creams could be applied. So for example, EMLA for an IM injection or lidocaine for a chest tube insertion. As you move down in the tiers, tier 3 would be acetaminophen, things like wound changes, dressing changes. And lastly, tier 4 is your opioids and or sedation. And tier 4 would be reserved for PICC insertion, intubation, or post-op management. So in our unit, we found that this tiered approach is really quite helpful in managing varying levels of pain in infants. So here's some examples. And my examples come from the neonatal intensive care unit. I would love to hear from others who work in different settings. But here are some things that we do in the NICU that arguably could be done at a different time. So avoid things that can wait. Does the head circumference need to be done shortly after birth? Do you have to have that chest x-ray to determine your endotracheal tube positioning? Slow and controlled handling. What about the use of non-sucrose UVC solution so we can check an infant's blood glucose from the lines as opposed to heel sticks? Can we use IV vitamin K instead of IM vitamin K? For centers who draw blood cultures, can it be done off the cord instead of a heel stick? Can you bundle phlebotomy so you're not doing a gas and then doing other blood work shortly thereafter? And can you rely on transcutaneous monitoring? And can we minimize or eliminate unplanned extubation. So once you've done all that in your unit and you've tried to avoid or minimize everything, and there's still things that need to be done, we're moving into tier 1. And this is your sucrose or non-nutritive sucking. So we've had quite a few systematic reviews and meta-analyses on the use of sucrose. We know it's safe and effective, and we know it reduces pain, behavioral, physiological pain responses to a single procedural painful event. The work that we just completed this year was to look at what is the minimal effective dose, and can sucrose be given repeatedly with the same level of efficacy. And we randomized infants to different doses, 0.1, 0.5, and 1 ml of sucrose. And we followed them over time. So for every painful procedure, we wanted to know what was the optimal dose. Did that dose continue to work? And then lastly, at 36 weeks, we looked at the neurobehavioral outcome. Our studies found that 0.1 ml of sucrose was as efficacious as higher doses. So many of our units in Toronto have moved to the minimal dose of 0.1. We also found that 0.1 continued to work over time. So the level of efficacy remained the same, whether it was the first dose or the 21st dose. And most importantly, when we looked at neurobehavioral outcomes at 36 months of age, we did not see any relationship between the total amount of sucrose given and the neurobehavioral outcomes of the infants at 36 months. So these data are the first to actually show that repeated doses of sucrose can be given to infants. The next body of literature is on non-nutritive sucking. And again, there has been some Cochrane reviews that shows that non-nutritive sucking does reduce pain responses in preterm infants, but it is most efficacious when it is combined with sucrose. So while non-nutritive sucking with a pacifier is helpful, when sucrose is added with it, its efficacy was much improved. So the question asked is, could it be done in the delivery room? Could we offer non-nutritive sucking in the delivery room? So let's talk about breastfeeding and breast milk, and they are actually quite different. So a Cochrane review showed that pain responses are diminished with both breastfeeding and breast milk, and we can look at the evidence later on in the presentation. They do reduce the behavioral responses, and what is quite unique is it is the act of breastfeeding that is more efficacious than breast milk alone. And so the question posed to people at resuscitations or in neonatal units is, could we consider donor milk for the use of pain management? Next is skin to skin. So a couple of Cochrane reviews looking at skin to skin, knowing it does reduce pain and stress in early life. Skin to skin should be maintained for 10 to 15 minutes prior to the painful procedure. And ideally, the mother or father should be in a kangaroo position for a minimum of 1 hour to get the most benefit from the experience. So tier 4, not the topic of today's conversation, but certainly something that needs to be considered when pain is severe or acute. Morphine and fentanyl are the gold standard. Morphine more so, at least in our centers, than fentanyl. It is known to have respiratory depression, hypotension, and it slows the GI tract. Compared to fentanyl, far more potent. The body loves fentanyl more than it loves morphine. There is less impact on the GI motility and hypotension. And I'd love to hear in the chat whether or not centers are using intranasal route of fentanyl, as we have just started that practice in our hospital. So this is a table that we put together in our unit to help guide clinicians as to what intervention can be used for what type of painful procedure. So for example, if you have a tape removal, you would want to offer sucrose and non-nutritive sucking, containment and positioning, skin-to-skin contact, breast milk, and a gentle technique. And you can follow down on the column on the left-hand side, depending on mild, moderate to severe, or severe pain. So going to the severe, as an example, endotracheal tube, we would recommend the use of atropine, morphine, or fentanyl, and succinylcholine would be an approach that our hospital would use for endotracheal tube. And I'm happy to share this, but we put this up in the nursery and in the delivery room so people are guided with what practices they can use. So let's move into sucrose. Sucrose has been around a long, long time, and the earliest evidence dates back to 325 BC, where the soldiers of Alexander the Great in India were using sucrose for pain management. It later spread, and it was introduced in the New World in the 1400s. And today it's a common sweetening agent, and generations have used it for calming effects. So if you think about what your mothers or your grandmothers or your great-grandmothers have used historically, dipping pacifiers in sugar, honey, some of the practices of giving sweet wine to infants having circumcision, the practice of sweetness to induce a calming effect has been around a long, long time. And arguably, the sweetness is used to hide the taste of many of our oral medications. When I started in the nursery, glycerin was used quite readily, long before we started using sucrose, but really it was the sweetness of glycerin that calmed infants. So we know about animal research. So going back to that endogenous opioid response from those 4 phases of pain response, animal research has shown that when a rat pup is given sucrose, they have less distress vocalization, and their latency, their paw latency, is changed in response to thermal pain. So they are able to withstand the painful procedure when sucrose is given. Alternatively, when water was given, there was no effect. So the rat pups continued to cry, and they lifted their paw quite quickly in response to a thermal pain response. So sweet taste-induced analgesia is reduced with Narcan. So again, suggesting that sucrose is working on an endogenous opioid response, helping with that modulation. It's actually working at that level of interpretation, whereas when you give Narcan, it removes the pain-relieving interventions of the sweetness, and the pain responses return. So saccharin was given 28 days in a row to rat pups. And what happened was that morphine was not effective in the rat pup, suggesting that the infant had become accustomed to the opioid-like response, and therefore morphine was not able to provide any pain relief. Similarly, Narcan did not have any effect. So the whole question of tolerance was raised. And really this was the genesis behind our study, where we wanted to see if you give sucrose repeatedly, 1, does it continue to work? And 2, does it have any long-term effect? So our latest study showed that, in fact, it did continue to work. It was not affected by morphine. We did not try Narcan, but we were happily relieved to see that pain management continued even after the 28 days that the animal models would suggest it didn't. Interesting enough, rat pups preferentially ingest sucrose over milk and over non-sweet solution. And this is true in infants as well. They will preferentially turn their head and ingest something that is sweet, as opposed to some of the infant formulas that are less sweet. So moving into the human research, we know that the taste receptors are evident by about the 8th week of gestation, and they're right at the tip of the tongue. So the sensory fibers from the tongue to the brainstem are established by 26 weeks gestation. So infants as early as 26 weeks can differentiate taste. And this is the point that I had made earlier, similar to animal models, that infants will preferentially choose a sweet taste over fat, proteins, or waters. And we see with their facial movements, they have facial relaxation, they start the hand, mouth behaviors, and their sucking, the rate of sucking increases in the presence of a sweet taste. And the hand-to-mouth behaviors only appear after the crying stops. So the hand goes into the mouth after the crying stops. So more on humans, the response of sucrose is rapid. It's usually around a minute before there's any pain-relieving experiences. It can last between 5 and 10 minutes after the painful procedure. Multiple studies have looked at a variety of concentrations, whether it was 7.5%, 12%, 24%, 50%. Most of the studies have used 24%, and none of the studies found any benefit to doses concentrations of sucrose greater than a 50%. Now, the early animal study showed that age and maturation decreases efficacy, and by about 2 months of age, sucrose was less efficacious. But the authors suggested that it's around 2 months of age where infants have different ways of modulating pain. They can be held by their parent. They can be provided breastfeeding. They can have a calming environment or parental presence. So it's not necessarily that the sucrose no longer has effect, but that other interventions are becoming more prominent. Our study did not show any difference at 2 months of age. We studied babies out until 4 months of age in the NICU, and there was no difference in the level of efficacy. So that type of research will continue. So I have 2 videos that I'd like to show that I'm sure any of you who have seen infants experiencing painful procedures, without me even saying what their title is, will know the difference. There's no audio, but you can see the response. The first one is performing a heel stick without sucrose. Okay, the heel lance has been done. You can see the arm going up. Baby is trying to cover his face, crying, body movement, arms and legs moving, and he's really thrashing around. And this is one that we did to show how the response is different when sucrose is given. 0.1 ml. Then you can see she proceeds with the heel stick, and compared to this baby in the previous, no body movement, baby's not crying, sucking on the soother, enjoying the soother. And the nurse is able to get the blood work without the baby in great distress. So in terms of non-nutritive sucking, much less is known about how non-nutritive sucking works. It is likely a combination of the oral tactile and the mechanoreceptors when the pacifier is put in the mouth. So non-nutritive sucking only works when the baby is actually sucking on the soother. It is not mediated through opioid pathways, so Narcan does absolutely nothing. And as I said, when the pacifier is removed from the mouth, the pain-relieving properties no longer exist. And again, in the animal models, it was shown that non-nutritive sucking allowed the rat pup to have decreased cry, and they were able to maintain their paw on a heat stimulus longer when they were sucking on an artificial teat. So breast milk and breastfeeding, again, a little unclear on the mechanics behind it, probably a combination of oral, tactile, and mechanical receptors. It is mediated through an opioid response, and I'm going to here. So there were 20 studies. 10 of them examined breastfeeding and 10 of them examined breast milk. So in infants who were in the breastfeeding group, they had significantly lower heart rate, crying time, the time to the first cry, their total crying time, compared to infants who were swaddled or held by their mother or given sucrose. So it was the act of breastfeeding that resulted in a decreased pain response. When we looked at the premature infant pain profile, which was the pain tool we were using to examine the responses, they were lower in the breastfeeding group compared to the positioning group, the placebo group, or the oral sucrose group. So there's something magical about breastfeeding. When we looked at breast milk, infants receiving breast milk had significantly lower heart rate, significantly lower increase in heart rate and reduction in the first crying compared to the placebo. So breast milk is better than placebo. Infants receiving breast milk had higher increase in heart rate compared to the sucrose. So breast milk did not seem to have the same level of pain control as the sucrose group. And sucrose, whether it was 12%, 20, or 25%, reduced the duration of crying compared to many other solutions. So sucrose of any kind had improved pain response compared to breast milk, glycine, non-nutritive sucking, rocking, or no intervention at all. So breast milk was not found to be effective in reducing the overall pain scores, whether it was the NIPS, the NFACS, or the DAN. It was only being significantly better when compared to placebo or massage. So breast milk is better than placebo, is better than massage. And no studies have examined the safety and efficacy of repeated administration of breastfeeding or supplemental breast milk for pain relief. So I wanted to put a couple of other things on here as what pain management strategies you can use in your settings. And one is the skin to skin. So it appears to be effective by lowering composite pain scores, physiological and behavior, and it does reduce crying time. And it has been shown to be safe for single painful procedures. It is not as efficacious as sucrose. It is not as efficacious as breast milk, but it is something that can be offered in various settings with parental participation. The caveat here is it appears to be safe for single painful procedures. To my knowledge, there is no data that looks at whether or not it is an ongoing, continuously efficacious strategy for managing pain. And really the question is, if the baby is so close to his mother or father's chest and we are doing painful procedures, is there an association with sitting on their mother or father's chest and having something painful done to them? So that work has not been done, and that question remains unanswered. So this is a very busy slide, and there's a series of a couple of slides that you can get the flavor of this. At the top, we're looking at, in response to a HEAL-ANS, infants were randomized to sucrose and non-nutritive sucking or water and non-nutritive sucking. And the outcome was the premature infant pain profile. And you can see the number of studies that use these two interventions. And at the bottom, you can see the overall effect favors sucrose and non-nutritive sucking over water and non-nutritive sucking. Similarly, when you looked at venipuncture, what is the most efficacious? Again, compared sucrose and pacifier with water and pacifier for pain responses to a venipuncture, and you can see that the favor sucrose is the best intervention for this procedure. Looking at IM, so babies were randomized to sucrose or water and pacifier. You can see the number of studies that looked at this. Although most of the studies favored sucrose, you can see the combined efficacy of all of the studies showed that sucrose is better than water and pacifier for IM pain. When we looked at the retinopathy of prematurity eye exams in infants, again, studies looked at sucrose compared to water and pacifier using the premature infant pain profile, and you can see that favored sucrose. So sucrose was better than water and pacifier for pain responses to eye exams. How about heel lances? So comparisons of sucrose and breastfeeding. So you can see there is no difference. Sucrose and breastfeeding, the active breastfeeding, were equally efficacious in decreasing pain responses to infants having heel lances. In studies that combined sucrose, pacifier, and mid-cap, positioning appropriate developmentally supportive care to infants, compared to breastfeeding alone, using the PIP as an outcome, again, no difference. So there is a magic in breastfeeding, the active breastfeeding, that reduces pain responses. And lastly, comparing different doses of sucrose compared to different doses of sucrose and EMLA for venipuncture, and again, no difference. So it is the sucrose that is efficacious. The EMLA did not change did not change the outcome. So there is no advantage to an EMLA for venipuncture if you're giving sucrose, 24% or 30%. So some other options for pain management. So touch and positioning. So we talked about the C-tactile fibers that translate the slow, dull type pain can be activated, can be modulated by positive touch and positioning. What we do know is there's a lack of gentle touches in the NICU or in the delivery room. So painful procedures should not be performed at the same time as other non-painful procedures. So take the time to have positive touch rather than doing positive touch at the same time as doing a heel stick or something painful, because then you accentuate the pain response. So what can you do in your unit or in your practice setting? So facilitate the opportunity for that infant to bring his or her hand to their mouth. Maintain that flexion containment. So if you think about in utero, what position that baby was in, so on the top right, that baby is flexed and contained and warmed. If you look at the picture on the bottom, that's often the way a baby presents in the delivery room. So can you help replicate or mimic that flexed, contained midline position? Deliberately provide non-painful touch. Spend the time to touch the baby in a comforting way. Enable the family to provide non-painful touch. Involve the parents and encourage hand hugs and parent cuddles. Some of these things we're starting to delve into what your environment could look like to minimize a pain response. So meaningful sound, such as voices of the parents, stimulates development. What we know is noise in excess of 45 decibels can have adverse effects on the growth and neurodevelopmental outcome of an infant. We know that loud noises are associated with apnea and bradycardia, hypertension, poor perfusion, and desaturation. For those of you who know about sound, 45 decibels is not very loud. And so most of our units are in about the 65 to 75 range, and they can certainly go higher. And the biggest source of noise, certainly in an NICU, are the people who work in the NICU. So what can you do? Well, you can limit the number of healthcare providers. So if you're in a delivery suite, keep the number of providers to the bare minimum that need to be there. You could monitor your sound level. Some units have gone to monitoring sound levels by a noise monitor, or somebody who indicates when the volumes are exceeding 45 decibels. And then I challenge all of us to think about what are some soothing sounds that could be offered to an infant, such as their mother's voice. So light, we know that light, supportive light reduces cortisol, it helps with sleep, it stimulates our growth hormones, and it starts to establish a circadian rhythm. So what could all of us do? We need procedural lights. There are times when we actually need to see what is happening, and those lights need to be at no less than 2,000 lux. But what we do know is in between sessions where we need bright lights, we can control the light at the infant level. So keeping the ambient light levels at infant spaces no less than 10, then it's very dark, and no more than 600. So can you have adjustable lighting options? Can you cover the infant's eyes, or can you cover the incubator? So in conclusion, there's immediate and long-term effects of pain. We know that the non-pharm, we didn't talk about the opioid or sedatives in this session, but we know that non-pharmacological interventions have efficacy. We want to minimize pain while maximizing the infant's own regulatory. So let them have their own endogenous opioid modulation. Promote that through the use of sucrose, non-nutritive sucking, pleasant touch, minimal light, minimal handling. Non-pharmacological measures should always be used with pharmacological measures to provide this synergistic effects, and we can create a positive pain experience. So what we can do now is avoid pain and stress where possible, use that tiered approach and avoid pain when we can, maximize our non-pharmacological interventions, and really work on that environment so that we've not got excessive noxious stimuli in addition to the procedures that we're doing. Always encourage the family integration and start to use a standardized approach to pain, whether it's the driver diagram that I described, or it's the chart on the wall that guides your clinicians as to what needs to be done for painful procedures, or some of the other techniques you would have in your unit. A standardized approach will be beneficial to the infant. And that's it. And I'm afraid that was very, very quick.
Thank you, Sharon, for that great presentation. We really appreciate it. We do have some time for questions and answers, which is great. Just a couple quick things while we're waiting for questions to come in. You can continue to submit your questions via the chat or the question panel, excuse me, and your certificates will be available Friday. Right after we end the webinar, a separate window will open up for the evaluation. So please make sure that you fill that out if you're needing the nursing contact hour for this. Sharon, the first question that came in is let's see, what does the research say regarding using sucrose before heel stick for blood sugar check? Is that recommended to use?
So that's a great question, and I would point us back to avoid things if you can. So if you must do a heel stick to check glucose for a diabetic baby, the evidence would suggest that sucrose does not increase your blood sugar. So if you cannot take the sugar check off of a line, you can do a heel stick, and there is no evidence to say that sucrose will artificially increase that serum blood sugar. So to answer your question, yes, it can be used in advance of a heel stick.
Okay, thank you. The next question is, someone wanted to clarify if NNS with sucrose is more effective than breastfeeding.
I will go back to that slide. So this sucrose and breastfeeding are similar. So if you have the choice, breastfeeding should be promoted. Yeah, there's no difference.
Thank you for that. The next question is, do you know the percentage of sucrose in sweeties?
24%.
The next question is, what about pain management during circumcision?
Yeah, again, so going back to if it can be avoided, that would be the first. If it is a requirement medically or family choice, this is our table. So circumcision, we would offer non-nutritive sucking and sucrose, contain the infant, positioning them, hold them. I know they're put into, at least in our hospital, into, well, I don't know what it's called. You place the baby inside of it, but someone could hold their head and provide some gentle, nice touch. We would provide a topical anesthetic, and we would support a penile block. So that is the gold standard for circumcision.
Okay, thank you for that. The next question is, I noticed diaper changes were listed as being somewhat painful in your presentation. Can you comment on that?
Yeah, this is coming out of our research for the extremely low birth weight infant, and they mount a similar response to diaper change as they do with handling. Increased heart rate, increased behavioral responses. Diaper changing shouldn't be painful, but we need to remember these tiny, extremely immature infants often can't distinguish between mild pain and moderate pain. So we see the same level of pain response to a diaper change. So what we offer, or what we recommend, is the log roll, or sliding a diaper under a baby so that the legs aren't lifted, they're not splayed open to put the diaper in place. The diaper is slid under the buttocks, and then if you have to, log roll the infant side to side. So we are, I guess, to answer your question, it is interpreted as a mild, painful procedure that we need to pay attention to it. And so we're recommending non-nutritive sucking, containment, again, so a nice contained, slow movement of the infant, skin-to-skin contact. You could use breast milk, but most importantly, a very gentle technique.
Okay, thank you. The next question is there a certain ideal time between sucrose administration and performing a painful procedure?
Great question. The onset is after 1 minute. So between 1 and 2 minutes, you should wait before the painful procedure. And they have to taste it. So remember that slide that says the sweet receptors is at the tip of the tongue? So we've done a lot of research where sucrose is delivered through the NG tube, and it is not efficacious. The infant has to taste it. So little syringe at the tip of their tongue, wait 1 or 2 minutes, and then proceed with the procedure.
Okay, thank you. The next question is there a study about the amount of stress or pain that a newborn at term goes by while staying in the postnatal ward?
Sorry, repeat that again.
Yes, they're wondering, is there a study about the amount of stress or pain that a newborn at term goes by, they say, but I think they said goes through while staying at the postnatal ward?
Yeah, no, it's a good question. I do know the preterm infant, that's who I study. So it's like 15 painful procedures per day. The term infant, I am not aware of anyone studying the frequency of painful procedures. Certainly in the delivery room, there would be, the vitamin K, there might have been suctioning, there may have been head molding. But if they're a healthy term infant, then that should be all. And then they would go to the postpartum unit. They would have their 24-hour labs done. So that would be an opportunity for sucrose, non-nutritive sucking, breastfeeding, maternal, paternal contact. But a healthy term infant that is with his or her parent really is having very minimal painful procedures done.
Okay, thank you for that. The next question is, would it make a difference in pain experience for the infant to breastfeed before and after a painful procedure?
Yeah, you really want to get that baby on the breast, for all of the goodness in breastfeeding. And while they're breastfeeding, you can do the painful procedure. It's usually a heel stick, might be an IV start, but it's usually a heel stick, and then certainly continue it after. Yes.
Okay, and this question kind of goes along with that question, taking a different approach. This question is there any evidence about breastfeeding during a heel stick or vein puncture and risk of some kind of aspiration? Some older nurses like to use that as a reason for not breastfeeding during procedures.
So the evidence would not suggest that that is a risk, and it certainly didn't come up in this systematic review. So I can't say with confidence. I have not heard that. I have not heard that. And there's no evidence that I am aware of that would say that a baby's going to aspirate. They could just as easily aspirate on sucrose, and they don't. When we studied any negative sequelae of sucrose, desaturation, bradys, and were examined, and we did not find any adverse events.
Okay, perfect. Thank you. The next question is, would giving newborn injections in the labor delivery room on the mom's belly help decrease pain for the term infant?
Yes. Yes, so skin to skin, although not as efficacious as breastfeeding or as sucrose, we do know it's better than nothing. We know it's better than on an overbed table. So absolutely put that baby on mommy's chest. It's the warmth, it's the comfort, it's hearing her heart rate, and it will decrease. Not as good as the other options, but certainly better than nothing.
Okay, thank you. Someone is asking if you can repeat the information about circumcision and how to handle it.
Yeah, let me go down to my table. So sucrose, non-nutritive sucking, and containment are promoted for almost all painful procedures. There are a few exceptions. So that goes with those two are, you must do number one and number two. With circumcision in particular, you've got your topical anesthetic, so your EMLA, your Amatop, and gold standard would say that the baby needs a dorsal penile block so that it completely diminishes the pain responses. So that's the gold standard. Many hospitals that don't have physicians, PAs, NPs skilled in a penile block would be giving the sucrose, non-nutritive sucking, and the Amatop or EMLA. But really, you could be asking in your centers, is there anyone with the expertise on a penile block? More and more centers are going towards that.
Thank you for giving that information again. The next question is, any suggestions on how to educate staff to increase breastfeeding during procedures, particularly during the PKU testing? Staff is resistive because it takes longer, which is more traumatic.
Yeah, that is a great, great question. It does take longer. It takes longer to have the, mother prepared and have her understand what's about to happen. It does take longer to get that infant onto the breast. All of those things are true. I think the staff need to understand, and I have said it to many of my colleagues, it's not about us and it's not about me. And so while I can do many of these procedures very quickly, that is not a measure of really anything, quite honestly. If the goal here is to minimize a painful experience, then we have to take the time to do it in a developmentally supportive way for the baby and for the family. So it's just having those conversations with the team, trying to understand what the barriers are. If the barriers are time, can we work together as teams? Can you choose a time where the other parent is able to help positioning the infant? If the issue is time, if the issue is fear, that aspiration, I don't want to promote something that might result in aspiration. Is it providing them knowledge or education or evidence to say there hasn't been any evidence to suggest infants aspirate? Is it, going back to those myths that people don't believe the infant has pain, so why would I need to do this procedure when infants don't experience pain? So I think you need to get at the heart of the matter to understand what is the barrier, and it's probably all three of those, and there's probably more there as well. I think focusing conversations around what is it we're trying to do, and we're trying to minimize pain in infants. We're not trying to make it easier for us. In fact, if you minimize pain in infants, it actually does make it easier for us. But the focus needs to be on what is it you're trying to solve, and it's the experience for the infant.
Okay, thank you. The next question, we have a few more minutes. So the next question is, on the chart, I don't see breastfeeding. Is that included in NNS?
No, and that's an excellent point, and breastfeeding should be here, and so I dearly apologize for that. Not included. Non-nutritive sucking is sucking on a pacifier. If there's a solution, whether it's breast milk or formula, it is not NNS. So all of the studies that say NNS, it is a pacifier. But that is great feedback, and we should include breastfeeding in some of these, many of these.
Okay, and since we're still on the chart, someone posted on the graph, the last word for pain support in ET intubation was cut off.
The last word on this chart. Oh, up at the top.
Or,
hang on. So it's we give atropine, fentanyl or morphine, and succinylcholine. So some type of paralytic agent, so that the baby is not able to move, and it's a controlled intubation.
okay, thank you. Looks like we have a couple more minutes. I'll try to squeeze in a couple more. The next question is, can you comment on the use of acetaminophen post-circumcision? How much and for how long?
Yeah, so the dose of acetaminophen is 15 milligrams per kilo per day, not to exceed 6 doses. If you don't want to exceed 90 milligrams per day, I would give it for 24 hours, and then I would not give it after that.
Okay, and then the next question.
And I guess I could go back to, and we didn't talk about it in this session, but you really want to be looking at the infant's physiological and behavioral responses. So if they're crying a lot, if they're not sleeping, if they're not able to eat, you want to do a pain score. And if the pain score indicates that they need something, then acetaminophen would be a good and safe option.
Okay, and then the last question we'll do is, what is the recommended time for lidocaine to be administered prior to the start of a circumcision?
So you would give lidocaine a couple of minutes before the procedure. Now, lidocaine in itself is painful to give. So you want to give the sucrose, the non-nutritive sucking, the containment, and then you give the lidocaine, because the needle hurts. But it's a couple of minutes before that painful procedure, the circumcision.
Okay, thank you very much. Looks like we're just about at the top of the hour. I want to thank you again, Sharon, for presenting this webinar today for us. Certificates, as a reminder, will be available Friday by logging into your accounts. You can download those there. And just after we end this webinar, there will be a separate window that pops up with the evaluation. So if you can fill that out. And please visit medilaeducation.com to learn more about the July 20th, August 17th, and September 14th webinars and to register. I hope everyone has a great afternoon. Thank you for joining us today.
Thank you.